Hello and welcome everyone to a very special episode of Humans of Pharma. I'm your host Pape from Pharma State Academy. Today's episode is not just a conversation, it's a powerful preview of one of the most relevant learning journeys in the pharmaceutical industry right now. A deep dive into market access, pricing, policy, and HEOR. This podcast brings together the brilliant minds behind a unique collaboration between Pharma State Academy and IIM Sirmaur, a program designed to equip pharma professionals with the strategic tools needed to navigate value-driven healthcare both in India and globally. With us today are some of the leading voices from industry and academia who will not only be speaking at the program but are actively shaping the way access, evidence, and policy intersect in pharma. So whether you are in medical affairs, marketing, public policy, or market access, this conversation is just for you. And now it's my absolute pleasure to introduce our panel for today's discussion, a group of exceptional professionals who bring together industry wisdom, academic depth, and real world perspective. Let's start with Mr. Ashis Mukherjee, Vice President and Global Head, Market Access and Reimbursement Primary and Specialty Care at Menarini Group. Ashis sir brings decades of global experience in building access and pricing strategies across diverse markets. His strategic insights into payer engagement and value creation are shaping how modern pharma defines success. Welcome, Ashis sir.
Thank you. Thank you, Pape.
Joining him is Dr. Minal Jain, founder and director of RxPremise, a pioneer in HEOR and real-world evidence space. Minal ma'am is known for translating complex data into actionable access strategies. She brings a unique perspective at the intersection of evidence, affordability, and policy. Welcome, Minal ma'am.
Thank
It's
you,
so
ma'am.
good to have you all here. We are also joined by Dr. Sanjay Sir, Associate Professor, Economics and Business Environment at IIM Sirmaur. Dr. Sanjay Sir brings a system-level view of healthcare policy, public health economics, and HTA frameworks. His insights help us bridge policy theory with pharma reality. Welcome, Sanjay Sir. Moving forward, we have Dr. Kiran Kumar, Assistant Professor, Decision Sciences at IIM Sirmaur. A specialist in predictive modeling and data analytics, Dr. Kiran adds the evidence-based thinking that's reshaping how pricing and access decisions are made in pharma today. Welcome, Kiran sir, in today's episode.
Thank you. Bye.
Adding to the academic strength of this panel is Dr. Manish sir, Assistant Professor, Pharma Strategy and Operations at IIM Sirmaur. With a strong background in supply chain and pharmaceutical operations, Dr. Manish sir draws attention to the operational levers of access, often overlooked, yet critical to implement. Welcome, sir.
Thank you very much for having me.
Yeah. And last but definitely not the least, we have Mr. Prasant sir, Director Government Affairs at OPPI India. Prasant sir offers a real-world view of India's evolving access and policy landscape shaped by years of experience in public-private engagement and regulatory strategy. Welcome, Prasant sir.
It's my pleasure to be part of this podcast today.
Yeah, welcome to each of you, and thank you for being part of this special episode. Let's let's dive straight into the conversation. And to start things off, let's begin with Ashis sir, who's been at the forefront of market access and pricing strategy across global markets. Ashis sir, today we hear a lot about how market access is becoming more central to pharma strategy. But I would love your take. Why do you think it's no longer just a nice to know topic, but actually a must have capability for professionals across roles?
Thank you, Pape. This is extremely important question at this stage. Why market access is becoming so important, so critical for overall market strategy, market penetration, market launch. If you look around across all the markets in the world, there are markets which are fully reimbursed markets, like developed markets like Europe, Japan, even some markets in Asia Pacific like Korea, Australia, and even in Middle East and Africa, which was not there like 10 years ago now, like Saudi is also now going for HTA implementation, and many others will follow, even in Middle East and Africa. And there, of course, South Africa is still a long way to go, but there are other markets, even in Middle East and Africa, also thinking about it. In Europe, of course, it is there. If you come to the South America, you have your major markets. If you want to be in the reimbursed segment, so there is a private segment there as well. But if you want to be there in the public space, then you have to go through this reimbursement process. The reason is all the payers across the world realizing with the newer molecules coming into the markets, there has to be a proper assessment of the molecules versus what was there in the past and what additional benefit it is bringing to treat those patients. So in terms of your unmet medical need, what kind of economic value or clinical value the new product brings in compared to the standard of care, what we call it, or the treatments already available. And the number of new products which are coming into the market or innovations coming into the market has seen all kinds of products, right from your, in terms of gene editing to small molecules. So you've got very expensive products, super expensive products for some of the disease where you do not have many solutions. At the same time, even for that matter, simple hypertension, blood pressure, for many patients, despite number of products, it is still not controlled. So what do you do with those patients with a high risk of having high blood pressure, despite giving 3 drugs maybe? So therefore, for the payers, particularly in the reimbursed market, where the payers pay, does everything. For an example, I'm sitting in Italy. In Italy, healthcare system, as a citizen, we are covered under public health. For an example, even for me also, I'm covered. And when I say I'm covered for everything you can think of, right from very expensive cancer treatment to CABG to everything which you can think of. Patients do not pay anything from their pockets, barring maybe a small number, which is very different than what you see in India. It is more like private market, you pay from your pockets. So the payers, those who are particularly looking at that, all these molecules coming in as newer discoveries or innovation, there must be a way to assess all these molecules on their economic value, clinical value, even to societal value. So what kind of value does it bring into the society as a whole, as a population? And therefore, this HTA or market access becomes more and more important. Even in India, there are a lot of discussions going on right now, including from the Ministry of Health, from the government of India, to see what would like to do with that, putting the market access or HTA framework in place to assess the newer molecules. So market access will become extremely, extremely challenging because the payers are becoming more and more smarter. They're using artificial intelligence. They're using all kinds of analytical tools to find out in the clinical trials, what are the endpoints, which you are looking at, the primary endpoints, secondary endpoints, and trying to find out. So they're going to really details, what I wanted to say in the very opening statement. They're going into much more details than what you've seen in the past. And they're really trying to say that whether it's really adding value or it doesn't add value. Okay, this is like nice to have. But, well, I mean, economic benefit, and Minal will tell you in a moment that, is it really cost effective? Is it really making sense for my budget? So, and that is why it is extremely important to know, and market access as a function is becoming more important in most of the multinational companies. They have a large team of market access function in almost all the multinational companies across. And therefore, in India, there is a large talent pool which may take advantage of this program to get trained in global market access landscape, and how do they can become one of those where those companies, either in India in the back office support or even in global headquarters, they could be a part of the market access team. And this is important. And this particular program has been tailor-made to provide that part of skill or education to those professionals who'd like to make a career in market access, not only in India, but also outside India for any other multinational companies. I hope I could address the questions that you had.
Thank you, Ashis. It really added value to our session today. For the next question is for Minal ma'am. I would now like to bring in Minal ma'am, who's been leading the conversation around HEOR and real-world evidence in the industry. Minal ma'am, you have been working deeply at the intersection of evidence and access for years. A lot of people still see HEOR and RWE as academic or post-launch checkboxes. But in your experience, how do these tools actually shape real pressing decisions today? Where do they go beyond theory?
Right. Thank you, Pape. So I think I would like to carry on where Ashis left and, not just talk about HEOR and RWE and how they are more than a theoretical concept today, but also tie up with the Indian healthcare market. And, like Ashis said, that nowadays we have a lot of Me Too drugs, right? And within Indian system or the Indian healthcare market, where it's so much fragmented, obviously there's a lot of burden of communicable, non-communicable diseases. The out of pocket is also very high, so making affordability also a big issue. And in such a setup, it becomes very critical to assess or tell the payers or the government which kind of drugs to reimburse, or even for the let's say for the insurance companies, right, whether to include a particular drug or an intervention in their formulary. And that's where the HER and RWE kicks in. We have to tell using these concepts whether a drug or an intervention is cost effective or not. And then the shift is also happening more from, like a market-based or a cost-based approach, where they're now talking about a value-based approach, right? Is this cost-effective? Does it bring, what is the value it brings, right? So I think this concept is, it's comparatively, it's old for the world now. I mean, it's already established in countries like UK, Canada, where they have a very solid HTA system in place. But when you talk about India, given the how the healthcare system is, it's still shaping up. It's largely driven by the cost aspect, and particularly with the government, the way they have these pricing caps, right, or price control policies. It's very difficult for pharma companies to come up with new innovative drugs and then ask for value or a high cost drug. So that's where HEOR comes in and says that, okay, this is a new drug or intervention. It might be very costly, but the benefit is also very high. That is the part that HEOR plays in. But what about the RWE? Where does RWE comes in, right? If you're talking about a clinical trial, which is happening in a very controlled environment, right? The clinical efficacy. But today we need to know what is the real world impact, right? Because if you're going to give the drug in the real world setting, the patient population is going to be very diverse. They're going to be having a lot of comorbidities, concomitant medications. Even the adherence pattern might be very different. So there, the real world has a very crucial role to play. It will give you the information, how will your drug behave in the real world market? And that will help these HTA bodies or the government agencies to make an informed decision whether they should be investing in such a product or not. So it's a very crucial thing where real world evidence comes into play. Again, if you talk about India again, I think it is still in a nascent stage, given you have private practice, you have hospitals, you have private clinicians. And it's very difficult, every majority of them are still paper-based, right? You're not collecting everything on an electronic health record, right? So to collate everything, get into a common portal or assess everything, maintaining data security, data privacy. I mean, the list is endless if you start going into that route. But I think somewhere there has to be a start, right? You need to it has a very crucial role to play. It's already very well established in other markets, but within India, it's still picking up. And we need to, a place like this or, programs like this are very crucial because they are going to upscale the people. They're going to tell people what is the importance. Why do we need to do this, right? People know what is RWE, but do they know how to actually do? I mean, the results have to be credible, right? I can do a RWE analysis. We've all studied stats some or the other time in our courses. We can do it. But whatever results we are producing, it has to be credible enough so that the policymakers or the clinical KOLs, they can actually rely on us and take it forward. So I think that shift has to happen. And this is the place where I think it should start. You have to give the physicians or the fresh graduates or whoever is interested in this kind of work, a forum where they can upscale and, even the stakeholder management, right? You need to have a place where people from different industries can come together. It could be the policymakers, it could be the clinical KOLs, or the pharmaceutical companies. They have to have this common platform where they can engage and then take this forward. So I think this kind of setup is very crucial for this to happen, and for this HEOR and the RWE, even the market access, everything to shape up within the healthcare system in India. I hope
Thank
that
you, Meena.
answers the question.
Yeah, thank you, Meena, ma'am. That was very incredibly insightful for our audience as well. And any quick thoughts from rest of the panel before we move ahead?
I just wanted to, for the audience particularly, just to expand the acronym. HTA is called Health Technology Assessment, and we have been using very frequently in our conversations. So I thought it would be good for the audience to know the Health Technology Assessment is a known word outside India. Even India also is pretty now being discussed, so it's nothing new. But just for the audience, they don't get what is HTA. It's about health technology assessment. So basically, as what Minal said, what I said, any new intervention, any drug, any innovation versus others, on a different level of evaluations, it is called health technology assessments.
That's an insightful take. To layer on the policy perspective, I would like now to bring in Dr. Sanjay sir. Dr. Sanjay sir, Sanjay sir, there's been a lot of buzz lately about India moving toward HTA-based decision making. But in your expert view, are we actually ready for that shift, or is it more of an ambition than a reality right now?
So while coming to India, it's a little difficult proposition, right? So, well, I mean, if I start with STA, which I think Ashis has already expanded the abbreviated form of that. So India has officially embraced HTA. So it's a kind of tool, and it has actually kind of inform evidence-based health policy, particularly in pricing, reimbursement, and coverage decision. Right. So India has actually moved forward, but whether it is actually ready or not, probably one has to really see that. But I would say India is actually gradually moving in the right direction. But we are really not ready. I mean, I would say, in my opinion, because there is a lack of real world data, right? So India lacks standardized national registries, patient level cost data, and long-term health outcomes. Right? So this is where I would say we are really not fully ready, but we are actually moving in the direction. Okay, so that's one. And if you see, like, we have a fragmented EHR system. So what is EHR system? EHR is basically electronic health records. So we have very poorly implemented outside private tertiary care. So it's not really, we can say, done very perfectly, right? And also to add to that, I would say there is a limited costing data. So while the National Health System cost database, in other words, we call it NHSCD, so it's basically a step forward, and it is incomplete. It's not complete at all, and not frequently updated. So these are the things which we really need to have a kind of look at it, and before we are really fully, ready to be part of it. And also we have capacity constraints, and there is a shortage of trained professionals in health economics, epidemiology, and modeling. And most of these technical expertise, it's still donor funded, I would say, or they are housed in a very handful of academic institutions, right? And with respect to the policy uptake, it is very uneven. And STA outputs are not yet systematically used in pricing or benefit package decisions. And with respect to the ministries, I would say ministries and the procurement bodies like NPPA, CGHS, etc., they lack the mandate or capacity to incorporate STA output. Okay, so there is a limited buy-in from private sector and the states. Okay, and there is a ethical and contextual challenges to that. The standard cost effectiveness threshold may ignore equity or rural-urban variation. That I think is very important to have a look at it. And STA risks being viewed as a rationing tool rather than one to promote value-based care. So everybody knows what is value-based care. So one has to really have before we really think that we are really ready, one has to really look at it. And probably India, I would say, is moving in the right direction for that matter. So I hope I have addressed your question. If not, probably you can, all of you can chip in and add to the value of my opinion. Thank you very much.
Thank you, Sanjay sir. That was an insightful perspective. Anyone want to add to that or share a different perspective from the group, from the panelists?
No, I agree with the professor. Very, 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 very nicely. He has captured all the points and fully, understand the current situation in India and all the points which you mentioned, professor, in terms of capacity, in terms of even the framework, the infrastructure, the lack of data, all of that. But at the same time, we are on the right track because I see a lot of discussions are going on. They accepted the HTA framework, government knows. Then the question about what is the threshold? Because like, for example, in UK, the threshold is for general products and cancer or rare disease. There are 2-3 different types of thresholds they have created depending on the unmet medical need or the value in the product, the way you assess. So all of this work will happen, of course, in India going forward. But in principle, as you said, which is very good to hear, in principle, India has agreed to this framework. It might take maybe 5 years, 10 years to reach there, perhaps, depending on a whole lot of factors.
Yeah, so the biggest thing India must fix before STA can truly work is its health data infrastructure. So which is not in place yet. So that's I think very important to my opinion.
Correct.
Yeah.
Thank you, Ashis sir and Sanjay sir, for your valuable insights. Let's now turn toward data and predictive analytics because decision making is only as good as the insights behind it. Dr. Kiran sir, you work so closely with analytics and modeling, and I think that's one area pharma professionals are still catching up on. In your view, how is data and analytics really changing the way we approach market access and pricing strategy today?
It's a great question, Pape. And
Thank you, sir.
you see, you are listening from Ashis sir, Minal ma'am, Sanjay sir. They were talking about all things, whatever the evidence they are saying, that evidence is nothing but data. So without the number, without some information, you can't take any decisions. So it is significantly changing and transforming the entire landscape of healthcare marketing access and pricing. Still, there are things that already the experts are saying about it, and even the data is required for whatever real world evidence and HTA. And we have some of the tools and techniques to mine the data and deep dig into the data to get the more insights from the from the data, and you can have lot of information. See, if you are able to take everything together, then at least you can make some proper decisions for that. And there are few things that needs to be added in the data and analytics field. And nowadays we are talking about all the precision segmentation. That means if you know these segmented people, where your patient segments, then you can able to take the decisions. And there is another thing that is now emerging, that payer sentiment analysis. So that is actually you are getting the sentiments from the different boards and social media, and even the how the payers are ready to pay all the access, and how they are able to access in the global levels. And the foremost thing that in the data set in the medical field, definitely, we can't do everything in clinical side and their bold evidences. We can't create. Okay, there comes the picture of simulation and creating the scenarios, how we can build out of everything, and even talking about pricing and volume trade-off. Okay, that is also one and more most important thing that that is bringing new innovations. And then again, cross country the relations, collaborations, how they were doing it, and cross country markets also. If you talk about American market and European market, and there will be different set of things. You can't see everything in a practical experimental area, and there the simulation you can bring and do something good, okay, for transforming the entire pricing strategies and that.
Thank you so much,
Yeah,
Dr. Kiran sir.
if you want to add anyone can add
Yeah, from the
something to that.
panelists.
Yeah.
I think what Dr. Kiran said is completely right. So one thing in my opinion, should be like looking at the real-time analysis, because that would be more important in terms of compliances and whether a particular drug which has been actually been launched in the market would probably real-time analysis would give you kind of cost-benefit analysis, which is very important in terms of whether we want to launch that product or not, because there is an alternative always, right? So particularly in the developing countries, like let's say, while analyzing this quality, QYLA or something like that. So one has to really look at, whether that particular drug, which is going to be very expensive, but it's going to actually, not be very affordable, right? So need to see what is the opportunity cost for that as well, right? So instead of looking at a couple of patients, we can look at a mass, right? So we have to really look at that, because real-time data analytics would actually provide that kind of insight, which is very much helpful for India, I guess, particularly the developing countries. So that's probably my opinion. Thank you.
Thank you, Sanjay sir. Thank you.
I would like to ask a question, Dr. Kiran, Sanjay sir, Minal ma'am, and Ashis sir, as you are all into HEOR and data, that in India we are collecting a lot of data and analyzing it. But are we taking correct decisions based on that data so that we can take good decisions whether a medicine would work or not work?
Maybe Minal, I don't know.
Kiran or Minal.
Yeah. No, it is actually it's a mix. The problem is now one thing I can say that nowadays we are talking about artificial intelligence, and the predictive modeling is increasingly using in pharmaceutical companies, and that particularly the high valued companies, they're investing more money on implementing artificial intelligence tools to predict the future thing for forecasts of everything. And even we are even building models for price elasticity, and even HTA we are talking about, but we are unable to get that, but we are making it prediction, and we are talking about the launching sequences. And even there is a growing shift towards evidence-based scenario plan. That is actually, I am telling you about the previous conversation also. The advanced simulation techniques required for doing all these things, but still we are lacking that tools to the Indian context. And the main problem is here, we are our Indian, or the main world is following really on historical analogs, expert judgments, and gut feel. Previously, previously we are following, and now also 50% of the decisions is made by the expert judgments. Okay, that is only there we are actually lagging, and even sometimes the reality and what is the observation, we are actually going far away from both of them. Means what we are expecting and what is you are getting reality, that is still lagging, that needs to be improved. Means even though you are creating so much of data, that is becoming garbage, because of you do not have expertise to explore new insights from the information. So that is becoming garbage only. Means we are unable to identify. But even the healthcare technologies also, they are bringing something every time. Means slowly they are adding one more item to the technology, so that it will capture the data, and then again it will mine the data to get the insightful information. But it is difficult for both of the things. But still we are growing together. That means we are using predictive analytics, using AI, and at the same time we are taking the judgments from the expert system also.
If I may also add to what
Yeah.
you said, Dr. Kiran, that
Yeah.
and also similar opinion, even Minal also mentioned that what is the quality which Professor Sanjay wanted to say, the quality, which is the value. For an example, a rare disease do not have many options, for an example. Now, the innovator of that company who has got this molecule, they like to price it very high. My question is then the debate could be why it should be high. It should be 10 times lower. This is one way of debating because India cannot afford. And there is no such data which says that this kind of rare disease only prevalent only in the poor people. Not necessary. This disease can
Yes.
impact anybody in the entire your socioeconomic status. Because our debate is not it is a poor country, so poor. No, I mean, there are super rich even in India also. Now, the question is that now at that price, what is the value? That means versus if you would not have treated that patient, or you would have treated with whatever, as you said, your current therapy alternative. And that is the quality which Minal said is extremely important to communicate. Now, the quality, the definition could be different for different countries, depending on the threshold, which is fine. But the issue is that also that we do not have, first of all, the people, as you said, who will, first of all, understand or need to build. Because, for example, any developed markets, all the payers have got a dedicated team to do this. They also have the data infrastructure. So, as you said, you simulate. So, when, as an industry, we do our simulation and we give it to the payers, they do their own simulation and challenge us. Because it is a two-way process. It's not that whatever I'm saying, it will be challenged by them. And they say, no, in your model, in your simulation, I believe there are some issues. The variables which you have picked up may not be the right variables. This is not the right cost. Your idea of so many days of hospital stay may not be true. The patient can go back much earlier. So the cost actually comes down. So they can, it's a debate, or it's a discussion which goes on with such authorities. And as you rightly said, that we need such approach at the regulatory level to ensure that we have such people. So I really like it is extremely valuable what you mentioned, Dr. Kiran.
Yeah. Thank you, sir.
So
Sorry, sir.
yeah, go ahead.
So just wanted to
what
add.
okay, go ahead. Sorry, go ahead.
So very quick thing. Just wanted to add, like even specifically for rare diseases or oncology, like we do a lot of predictive modeling even in health economics. But sometimes, you know, the HTAs will come back and say they will do their own analysis and they will question us. This is not the right extrapolation. Or if we are predicting mortality, let's say at 10 years, right? At the same point of time, this is where the RWE also plays a role, right? You go back to the RWE data and see, because that is the claims databases, right? And especially in the Indian setup with the Ayushman Bharat coming in, you will have at the end of the day a very good claims database. I mean, maybe not robust or, you know, in terms of data collection, but at the end of the day, this is one of the major national databases that you will have, right? And then you can see what are the long-term impact and try to correlate with your predictive modeling, right? I mean, whatever we are predicting at 10 years, is the mortality rate similar or not? So I think it has to work in you know, together, and then come up again. You know, the topic that you asked about, is it robust enough? Is it it's not, should not be garbage in, garbage out, right? I think that is where you need to have those standardization measures, right? You need to make sure that whatever data is being collected, you need to train those people at the ground level. So I think it's not just about us doing these analysis and, you know, getting people trained in health economics, but what about the people at the ground level who are doing this data capturing, right? Are they capturing the right things? Are they understanding the variables or not, and then capturing the right outcomes or not? So I think it cannot be, you know, we cannot target one industry or one focal point and say, okay, we're going to make this better, but it has to be a continuous, you know, throughout the continuum. We have to make sure that at every point it's happening in a proper standardized manner. Otherwise, as you said, Pranav, it will be garbage in, garbage out. Whatever sense you're making, your clinical trial might say something, RWE might say something, and you know, RWE might be essentially, it's not really the actual result that a drug could give. But yeah, sorry, Sanjay sir. Yeah, go ahead.
No, it's okay. So you have really hits the bull's eye. So basically what I was trying to say, what you mentioned just right now. So there is no standardized health outcomes tracking. So that would make calculation of quali or daily speculative. That's what I wanted to say.
Right. I mean, I was just reading, and I'm not very I don't have a lot of idea around this, but I know there's this government agencies that they have rolled out this NDHM. So they're trying to digitize the entire healthcare you know, probably collection. But I'm hoping that will also help towards the standardization of the process. It might be a slow journey, but I think somewhere we have to start, and we have already started that. So hopefully in the next few years, we should be able to see that change.
I just wanted to bring it.
So
Sorry.
Slow and steady wins the race. Let's look forward to that as well.
I wanted to bring another very interesting element, because I remember, like Prashant also will remember, that we used to do this similar together. I'm talking about like 2015, 2014, that period, so almost like 10 years back. And I don't know how many of you realize that if, you know, okay, we have a 1.4 billion, 1.3 billion people, so we do not have the infrastructure. But interestingly, you know, that if you look at some of the government organizations like ESIC, Indian Railways, Indian Army, put together, and if you take only ESIC, you know how many lives do they cover? Any idea? You'll be shocked, which is in the size of France. So roughly speaking, 7 crore lives are being managed by the ESIC corporation, ESIC in India. Do they have the data? Yes. Do they have the data longitudinally? Yes. Anybody seeing in that? Question mark. Do they have the capacity? Question mark. But the data is there. So it is very interesting. And it struck me, because I remember me and Prashant used to work in ESIC together. And we saw that, and not only that, Professor Sanjay, just to let you know, in the South, I remember even 15 years or 20 years ago, perhaps, in one of these steel plant hospitals, the patients, and the doctor told me that, you know, he took a X-ray, and I said, where is the X-ray plate? And he told me 20 years ago that nobody goes with the X-ray plate from one place to another place here. I said, what? He said, because this is in a chip. So you have a number, you come to me with a number, and I can put it on my computer. He showed it to me. So the guy who I sent him to do the X-ray, he doesn't come with a plate to me. I see it on my screen. So India, as you said, I feel it's quite advanced, but it is in islands, it's all fragmented. Now, how do we, even if we start working with one such health system, even ESIC for that matter, during my time, it was like 7 crore people. Well, now could be more. They have their own setup, their own hospitals, their own tertiary care. Some of the ESIC hospitals, I don't know how many of them, because normally we don't go there perhaps. It looks like Apollo hospitals. Okay. So it's no way, I'm sorry, I'm using the name Apollo, but this is pretty advanced, because some or other, the general belief is, ESIC, it's not that great. No, it is, some of the hospitals is amazing, the way they have built it. So I just wanted to bring in that element of it is highly fragmented in India, and somewhere we can begin this work.
Just to add on what Ashish said regarding this Ayushman Bharat digital mission, it's something which is a game changer. It's a mandatory for all government, even for the private hospitals, to make this data. And this data is going to be change the way we look at the patient. You are mentioning about the patient thing. The vision they are having, the one card or the one number, by one number, anybody can see the things across the India. If I'm in Delhi, going to Odisha, have some issue, visiting some district hospital, by Abha ID, they call it this ID, you can see my history. So the things are progressing, that the data is there, it's fragmented, but vision is very clear. They want to digitalize the things in India, the health delivery system, and Ayushman Bharat is one of the flagship program, which is, I think, all the things which we had a discussion, just all of the previous speaker talking about the STA, the Ayushman Bharat or National Health Authority in India, they're using STA to finalize their HPP, which we have never ever heard in the past. So things are moving, sound bites are coming. It will take some time. I think so.
Okay, thank you all for all this diverse and thoughtful perspective. And let's move forward to our next question. Next, I would like to bring in Dr. Manish sir to explore some of the lenses, less obvious yet critical operational factors that impact access. Dr. Manish sir, we often talk about access in terms of pricing or policy, but there are so many operational layers that quietly shape it too. From your perspective, what are some of the unseen elements like supply chain gaps or institutional risk that significantly influence access, especially here in India?
Thank you for that question. And I think I was listening to the panelists, and some of the aspects, I mean, if we draw from the academic parlance of supply chain operations and link it with whatever we have been discussing till now. So first of all, if I were to summarize the supply chain from a pharma perspective, and from the healthcare perspective, perhaps we might be comfortable with this term, like let's say from plant to patients, P2P, right? So the movement of the pharma goods and the services from the plant where the production is happening to the patients, and the entire gamut of things that happens within that. And within this entire set of things, what Ashish sir was mentioning, Minal man was mentioning, one of the aspects is how do you move these goods? Given that the molecules themselves are becoming complex, you have different, let's say, classes and types of drugs. Some of them might require moving them at very low temperatures, let's say. Right? So how do you move them from the plant itself to the patients in such a manner and across the hinterlands, across the diverse regions of the country, wherein, let's say, the Himalayas, you have a temperature which goes into negative, and in the you also have deserts where the temperature goes over 50. So in these diverse geographical regions, how do you move, given that you have villages and various other rural populations that you need to cater? Right. So within that, lot of work and lot of initiatives need to be taken. Right. And there are a lot of learning opportunities also. The reason is if let's say the cold supply chain in India, it's highly fragmented and it's highly diverse. Okay, and you do not have proper monitoring technologies for the trucks which are moving. Right? So how do you change this infrastructure? Right. So that is one aspect. Coming to the second part, which Ashish sir was mentioning just now, related to pricing. Okay, so there are two aspects to it. One is if you I would just like to take this example in 2024, around the end of 2024, there was a set of ceiling prices that were announced on medicines. Now, if you set ceiling prices on medicines from a regulatory perspective, it helps to protect and get the medicines delivered to the people who need it the most. But you look at the other side of it, the companies who are manufacturing it, right? The producers or the plants, they get hampered. I mean, so for some of the medicines, they might find their costs to be too high, right? For producing that. So in the end, they might shut down their production needs. Now, when you are looking at this, perhaps you might need to take a data-centric approach, which some of us, Sanjay sir, Kiran sir was telling us about. And when you want to take a data-centric approach, you need to get the data in a sufficient manner so that whatever hypothesis, whatever thought you are having, you know exactly that this price or this quality is sufficient and is good enough. Because let's say if the medicine reaches, but it's not of a proper level, or if the cost is too high, then it's of no use. It's a wastage. So with the proper data, even if we are capturing it, how do we get it to the people in a proper manner, and how do we set the prices based upon a data analytics? How do we do demand forecasting, right? So therein lies a lot of opportunities as well as, and when we have the infrastructure in place, which the government is working on, and we are moving towards that domain. And as Ashish sir was mentioning, we now have, I mean, the entire thing is digitized. I mean, ESI hospitals themselves are transferring the data for X-rays, etc., on a digital medium, right? So if we have that infrastructure available with us, can we do some mining on it? Can we be able to price our products? Can we be able to do the accurate demand forecasting so that the wastage goes down? Consequently, the cost goes down. At the transfer points within the supply chain, our network design, the supply chain design is in such a manner that the ability to transport the goods, that improves a lot. Okay, and we are able to do it at a lower cost, because at these touch points and with these local suppliers, it is often very difficult to measure the quality of the goods that are getting transported. Okay, so all these things taken into consideration, data analytics becomes very important. But the point is, sometimes we might not be able to get the data to the analysts, and we might not have analysts to, if we even have the data, to analyze them. So therein, I think, lies the opportunity, and we need more people, right, to do all these things, which unfortunately, as we are digitizing, we do not have. So I just wanted to put forward these few points from a supply chain perspective, wherein this movement of plant to patient of the goods, right, the P2P model becomes important.
Thank you, Manish sir. That was a strong point. Anyone else want to add few points in before we continue?
No, very well captured by, very well captured by Professor Manish. I think you're absolutely rightly captured. It's such a vast country, and again, I'm looking backwards. I remember one such state I cannot name for the confidentiality reason. It's a small state in the northeastern part of the country, and we're thinking about vaccination. And we realized there is not enough cold storage facilities to store, to vaccinate so many, that age group of children to be vaccinated. It was planned school-based vaccination program. So to your point, we need to take the vaccine close to the school from where it is manufactured. And we realized that we cannot, because there is no storage. There is no cold storage there. Then you have to maintain the temperature as you take the vaccine. Otherwise, vaccine doesn't work. So it's a very important problem. But I think, as you said, that India is also working. They know that they are also planning different points. Now the cold rooms are also being built in multiple locations. And that was a hilly terrain. We realized that a couple of schools are at a place where it's not easy even for anybody to go there. Even the road conditions are not so good. So it was a very unique challenge to your particular point. So I was reflecting back, the kind of discussion. We were sitting with the health minister's office and we are discussing this, what to do it. It's not easy.
I totally agree with you, Ashis sir. Ashis sir, still in the northeastern part, just the road connectivity is still a problem till now. Okay, thank you, everyone. So, and now tying it all together from a policy and industry leadership perspective, I would love to hear from Prashant sir. Prashant sir, you have had a ringside view of how access designs are shaped in India. In your experience, who's really driving those decisions today? Is it government bodies, the industry, hospitals, or a mix of all? And how does that balance shift in different scenarios?
Thanks. Very interesting question. I would say that who is really influencing access decision in India today? So, as per my understanding, I would say that access decisions in India are shaped by the complex interplay of three primary stakeholders. The one, definitely the government, the industry, the hospitals. But the dominant influence lies with the government. Why it is so? Because the government, the principal decision maker, through policy influence, like someone was mentioning about the DPCO, under the MPPA, the DPCO, which is deciding the pricing of the drugs in India. If you look at the other options, if you look at the government schemes which are coming, free drug delivery under Jan Aushadhi, Amrut, and few more free drug delivery or the Jan Aushadhi Kendra across the country, health schemes like Ayushman Bharat, which is also the part of where the government is influencing the access of healthcare as well as the drug in India, and the evolving regulatory mechanism. We have been talking about the STA, HEOR. The government set the direction and boundaries, I would say, of market access. The states also, if we have the health is state matter, the states also exert growing influence through their own tenders, their own formularies, and health insurance models. They are having different models they are following in India. That is the one aspect. For an example, like the STA is now, this STA framework is increasingly shaping which drugs are delivered, which medtech device need to be used in healthcare benefit package, and how public procurement, the reimbursement or inclusion of essential medicines will be part of any essential drug list. So HEOR and STA are getting into the picture and which are being governed in India by DHR in India. DHR is having across the country STA centers. We have designated STA centers in India now. So too much of influence from access point of view from the government, from industry, which we are all are the part of, because we are shaping strategy, responding to policy most of the time. While we bring innovation as an industry and engagement strategies, like we have been influencing more reactive than directive as an industry. We do have partnership with government. We have been supporting government in different programs, like if any national program of NCD or a TB elimination or for the AIDS with the NACO, for the other programs, the industry is collaborating with the government and building access models. But pricing and policy constraint limits leverage. We have the constraint of pricing it is coming into. If you want a partnership with the state, this issue is pitching into. For example, like for the new product launches, we often face delayed market uptake due to state level procurement policies. We have in India, Make in India policies coming off, or non-inclusion public formulations. every state and every center level, we are having formularies. So we are not the part of, even we are having innovative product in market, but it may not be available in the right population to use that product. And definitely, for me, the hospitals are the operational gatekeepers. They not policy makers, but they are private hospitals as well as the public hospitals or at the point of care in tier 1 cities. They influences prescribing behavior, access to the private market, but the policy influence is limited at hospital level. And in the public sector, definitely they operate within the framework set by the government. So if you want, I conclude this, I would say that all the three stakeholders play a role, but the government is a central force, whether it's the federal government or the state government, in access decision today in India. They are setting the rules, defining affordability, and increasingly deciding what gets reimbursed, procured, even prescribed in the public system. So industry and hospital must align with this evolving landscape to truly influence the outcome. That is one aspect which is very critical and important, how industry and the caregiver or hospitals are aligning. So this is from my side. Open to, if someone want to add, they can add also.
Yes, any panelists would like to add their perspective?
No, this all very nicely you put it, Prashant, because the government is playing more and more increasing role in this to shape. And absolutely, we are on the right track to do it. And also, it would be nice to look at, as I said, not like the entire population and see it's a massive problem, so, or we can see there are islands of excellence where most of this information is available. And there, HEOR or HTA or this kind of evaluation can actually work. For example, like the procurement process by various governments, as you said, can HTA be applied? Because we know there are multiple generics in India because of cost. Now, how can we use some of these technologies? And I was looking at, for example, that how many countries actually implemented at the national level the HTA process. And the number is roughly around 100 and little more than 100 countries across the world. Now, these are all big countries, small countries like Singapore, Malaysia also there. Even as I said that even, of course, developed countries are there. Some of the developing countries are there. So all of them are trying to do this because it's becoming more and more challenging for the payers what to reimburse and what not to reimburse. And if I decide to do the reimburse, at which price I'll reimburse. And that should come through this process because it cannot be like a cost-based approach all the time. Because if you do the cost-based approach for a rare disease, perhaps you will not, or perhaps you will miss out certain other values which you get versus maybe in any other disease. So these two things are very different when there are less options. So I see this particular, again, coming back to from where we started, this discussion of this, having this kind of skill building is extremely important within India. There are various talents. When I work across and when I see all the global teams outside India, particularly in HEOR, and Minal, correct me if I'm wrong, or even in market access, there are a lot of Indians, lots, sitting there. Not in India, but many times India, but even outside India. So we have a large pool of talents sitting in India to do this. And there, I'm sure with all the encouragement, guidance from the government of India, definitely this could be an interesting area to evolve going forward. So this is not nice to have where you started, Pape. So it is extremely important to have this skill now going forward.
Thank you so much, Ashis, for your insightful information. Yes, Dr. Mani sir, many people in commercial or brand roles still feel access and pricing isn't their concern. Why do you think that mindset needs to change, and why is this knowledge becoming critical for everyone in pharma?
Yeah, thank you, ma'am, for that question. Taking cues from what we had been discussing, the plant to patient approach. Within supply chain management, there is also one specific concept which is known as the push to pull approach, right? So push approach is followed by FMCG companies, for instance, wherein what they do is they will manufacture things in huge lot, and then they will push those products in the market. So, for instance, if you are going to buy, let's say, soap, you will find that on the shelf of the retail outlet where you are going to buy. This approach is different when it comes to cars, for instance, right? Cars work on a pull approach or a just-in-time kind of a model. Okay, you want something, it will get produced and then it will get delivered to you. What is happening in the pharma industry is that the industry is now transitioning from a push-based approach to a pull-based approach. So the entire supply chain is getting revamped. Consequently, when you look at, now given we are moving from a push-based approach to a pull-based approach, consequently, if you look at that, you will see that there are many different kinds of roles that are emerging, or many different kinds of technologies or different things that are changing within the supply chain itself. Okay, so there I think lies the opportunity. So, for instance, if you think about demand forecasting, in a push method, you would just push the products to the market and keep on producing at a certain rate. But when you are looking at a pull kind of a demand system, you want to get that feedback from the market on a real-time basis, integrate it into your decision-making process using advanced decision-making forecasting techniques, which are time series based. So, for instance, Sarima, Cars, Ars, etc., and then take the answers that you are getting and tailor your production accordingly. Again, if you are looking at the gamut of products that are getting manufactured, as Ashis sir was saying, that you have so many different molecules, so many different kinds of products. Okay? So when you're looking at that, how do you manufacture so as to, across your different production lines, so as to cater to all these different things? Taking cues from what Minal ma'am was saying, in different countries, okay, if you look at, there is a concept in operations and supply chain management called customer value, right? So what we typically try to do is we try to keep our costs in such a manner within the supply chain that we are able to meet the requirements of the customer or meet their customer value, which is a completely intangible concept, right? So paying for a particular product is different from what the intangible value of that product is in the mind of a customer. So, for instance, for a medicine, as Ashis sir was mentioning, the value in the mind of a customer will be different, or the price that he or she would be willing to pay for that product would be different from what he or she would be willing to pay for in India. Okay. Now, given the diversity that we have in our country, right, how do we match both these things? Okay, how do we do the data analytics, right? So these aspects become very crucial when you are looking at a pull kind of a mechanism. Okay, and there are other aspects to it also, right? So, for instance, if you are looking at, let's say, producing in some other country, okay, and then exporting it to some other country, what are the global supply chain considerations that you are having? Okay? In India, fortunately, during the COVID and today also is a huge manufacturer and a supplier to the entire world of medicines. Okay, the world in many cases is dependent upon us for some of the medicines. Now, given that we have a global production or a global set of people to cater to, how do we go about doing the production? So that becomes another crucial aspect. Then comes the stratification or the segmentation of the different kinds of customers for different types of products which the company is making, right? Also comes with it the research and development costs, the fixed costs and the variable costs that go along, and the recovery of those costs, given that some of the pharma companies might also collaborate for developing new molecules. So all these different aspects are changing when we are moving from, let's say, a push-based mechanism to a pull-based mechanism, wherein we are more reactive rather than depending upon past signals and then just producing accordingly. So that I think needs to be taken into consideration, because all these different types of roles, all the roles that are there in the supply chain are changing. The analytics part is changing. Okay. And obviously, as a consequence of that, cross-training and training people in different mannerisms.
Thank you so much, sir. Thank you so much for your very insightful information. Coming back to Ashis, sir. Sir, pricing frameworks are changing everywhere, and with payer pressure growing, what do you think professionals in India need to start doing now to stay ahead and be better prepared?
A difficult question. So, because as Dr. Sanjay or even in fact, I think Dr. Manish also mentioned, or even Dr. Kiran said in terms of modeling, simulation, all related to the pricing. We need a different skill to do this. So the first thing is that do we have enough skill to really show the value in the product versus the alternatives, or, for a better word, because in our language, we call it standard of care or other comparators, very strictly our technical language of market access. We call it comparators or standard of care. What is the value? And finally, the value will determine the price. Now, price, again, depending on what kind of product are you talking about. So for an example, you are talking about, say, hypertension, and you have a large population. When you're talking about rare disease, you have a handful of population. Patient number is small. So a product, an innovation for a small group of patients versus a large pool of patients. Why is it important? Because for the payers, they need to pay for large pool of patients, or they need to pay for a small pool of patients. This is just one element. Then, of course, you need to see that in terms of the benefit, particularly which what Minal said. What is that? The quality? What is that additional benefit in terms of the economic benefit, measurable benefit we are able to bring in, so that we command that price? Now, it also outside India, most of the countries, they have a very, very strict formula to do this. So you have to follow that process. So if you go to, for an example, in Germany or in France, first they have a team of people who do the benefit assessment. And if in case your product is assessed as no benefit, no additional benefit, then ideally by law, remember, by law, your product almost ideally should be treated with your generics. But then the HEOR comes in, and other data comes in to say that why it can be slightly different. So we really need to figure out how do you build your pricing strategy for a group of patients in that particular country with the data what you have. So you have to look at the claims data. You have to look at the, out of those the hypertensive patients, how many of them are treated with what kind of molecule? How many of them are on 2 drugs? How many of them are on 3 drugs? Still not controlled. I'm just giving an example. So the question, your drug comes in and you say that, well, even after the 3rd drug, still not under control. So you're positioning your product as the 4th alternative. So that means the 3 drugs, the patients are already on 3 drugs. And these patients may be age of 70, having other issues of high cholesterol. So really need to go into the details of each patient, or a group of patients. So they have got other risk factors. And why is it important? Why I'm saying this? Because depending on the risk factors, you can say that what kind of morbidity, and that might require hospitalization, which is a cost. So it is not the drug cost alone. It is also the hospitalization cost. It is other cost, as other hidden cost, as Manish was saying, particularly for the supply chain. But here also there are a lot of hidden costs. If you add all of that and say, hey, I'm actually saving all of these costs, if you take this one as the fourth line. So you're not then, what are you doing? In other words, you're not saying all hypertensive patients has to be treated with my new drug. No, we are saying the third line failure, which is actually you start with a high base and then you filter it and come at the top with some in a group of patients who are still not controlled, having high risk, other risk factors, maybe diabetes, maybe already other heart issues, or maybe not so mobile, maybe smoker, maybe a drinker. So, and now you say, okay, for this group of patients, then maybe this particular drug can help us to, go down on blood pressure. And now after doing all of that, Pape, then we talk about that, okay, then what will be the price the government is willing to pay? And this is very interesting. And Dr. Kiran was mentioning that there are some countries, they may say, well, I'm willing to pay, but I do not have the ability to pay. So the paying, there are two paths to it. So willingness on ability. Say, hey, I'm willing. I get the point. It adds value. This is all fantastic. But by the way, my budget is, unfortunately, is this much. So what can I do? So that ability to pay, then how do we address the ability to pay? And what is that? So therefore, then pricing, one part of the pricing, then next to the pricing, there are multiple different ways of what they call it, value-based contracting comes in. So you are not like paying for each patient, like, like it's your Netflix model, what we very popular in now pharma value-based contracting. It's becoming more and more popular. Netflix, they call it Netflix model, subscription model. So they say that we will use this drug. It really doesn't matter how many patients, I'll give you this much money. Even if we don't use for one patient, it's fine. I'll give you this money. Will you agree? And of course, this depends on a whole lot of your own analysis. Does it make sense, economic sense for you? Will you lose money? Will you, so both the authorities as well as the manufacturers, they do their own homework and then they discuss together whether this makes sense. If the ticket size is good enough for them, economically making sense. So pricing has got multiple facets now. So it is not definitely, most of the time, it is nowhere, it is cost-based approach, particularly where the reimbursed market is. So it is extremely value-driven approach. If there is less value, no value, then accordingly it is priced. But the moment you can prove that it is additional value, then of course your probability of getting a better price goes up. And also, as I said, there are multiple elements to the pricing, which is the patient numbers. The question is the unmet medical need. For an example, hypertension is a very crowded market. There are so many molecules. Now, everyone claims that I'm doing this much. Everyone has got their own clinical data to prove that point. Now, what additional benefit you will bring in, it's not easy always. So you are talking about third line failure. So first of all, the authorities might say also, how do I know that how many patients are there in my system who are failing on third line if I don't have a database? No, I agree with you. But how do I know who are these patients who are failing after third line? And I remember this similar discussion we had, again, for confidentiality, I cannot say, at some point of time in India, we were working on HIV, and many patients were coming and telling that they are, HIV, there is a, public health program, very, very successful program. It is one of the best, perhaps, in the world. But they were saying there are patients who are failing on the second line. But the government did not have the data to say how many patients are failing on second line, Ashish. I agree with you, but give me the data. Now, then accordingly, the price will happen. Because if I don't see any gap, any unmet medical need, because market access starts with unmet medical need. Is there any unmet medical need? The answer is yes. How big? Now, how big is only patient numbers? No. As Minal said, it is also in terms of the value also. You need to monetize that. Okay, this costs so much of billions of rupees if you do not do this. So this is like, we need to be prepared. And for the value-based, even Dr. Sanjay also mentioned, we are on the right track. Are we there? No, we are not there. Will it take time? Yes, it will take time. but definitely in India. But outside India, it is mostly driven by at least the national level, and also maybe another a few seconds. So usually the countries, they fix the reimbursement criteria and the price at the national level. So for example, in Italy, where I sit, they fix the reimbursement condition and also the pricing. But in Italy, why I said Italy? Because there are a number of provinces in Italy. Now, each one of them again can negotiate with you on the price. So once you do the pricing and the reimbursement at the national level, there is also another layer. And this is not true everywhere. Like in UK, we don't have to do at the sub-national level. We just do the national level. Similarly, in Germany also, we do not have to do, but if it is a hospital product, then perhaps hospital by hospital, there must be some negotiations. But that negotiations may be on the, as I said, value-based contracting models. But this is what the national level, usually you normally get negotiated price and negotiated reimbursement conditions. And to the extent of reimbursement conditions, there are, Dr. Sanja, many countries, they say that this particular drug, as it is expensive, I will not allow the GPs to prescribe this product. So the GPs cannot prescribe in that country. Now in India, to make it happen, it will take time. It will happen eventually. But in that system, the GPs cannot prescribe means cannot prescribe. There is no question of ifs and buts. No, GPs cannot prescribe. So it has to be prescribed by the specialist. And that control they have in those countries. So the price times the volume gives you your particularly the value which the government has to pay. So, and they have a budget to manage. So the pricing has to take into account all of these factors when they decide the value-based pricing. So it's quite interesting subject. It will become more interesting going forward. Lot of modeling which will be required, as Dr. Kiran, you said, to prove this particular point to the authorities, that why the price should be this, why price should not be below this, and there must be a reason for that. And there should be a healthy conversation. It is not like in China, FDA or China, if you want to enter into the Chinese essential list of medicine, this is no negotiation. They call it a negotiation, but there's no negotiation. So you enter, they will tell you your price is 100 euro. They said, I'll give you 10 euro. You tell me whether you are fine with it or not. I give you half an hour. You can go and talk to your people, phone a friend, whatever, like KBC style, and then come back and say whether it's fine or not. So 10 times less, and that is what it is. So either you are there or you are not there. But in most of the developed countries, it's a very nice, dialogue. I would not say that there's a much leeway, provided you do your homework through all the models which I said. Then you have a strong value story, value narrative with evidence. Nobody will believe you what you say. It's all backed up by the evidence, models, data. Stop here. It's a challenging area, so to get time to explain.
Sir, do we have a model in case of emergency situations? For example, during the COVID period, many people were facing a disease of black fungus, mucormycosis, and the drug used for the treatment, amphotericin B, was very costly that time. So did we have any protective model regarding that so people can treat themselves?
Kiran or anyone
from government point of view, they have certain measures to control the price of drugs. It could be essentiality, the condition like pandemic we had in COVID. They put the drug under the NLEM, National List of Essential Medicine, automatically become the part of DPCO, and the ceiling price fixed by the government. So everyone who is having the drug available in India, they need to sell below the ceiling price. They cannot increase the price. So that is why this pricing model in India, the essentiality criteria, which comes from a public health concern from a government side, the government perspective is a need for public health. They can take such decision, and they took such decision in the time of COVID also. We do not have many of the precedents in the past. We have 2 to 3 precedents in the past where they have reduced the price or they put the drug under price control for the disease like cancer, the oncology in the 2019 or 2022 part. They put the drugs under the DPCO. So we have that sort of mechanism of controlling the price in India?
Thank you, everyone.
Ashish.
I know, Ashis, yes.
There's another important element for everyone to notice, and why it is important for us to build the skill, as
Yes.
the question was, because this pricing scenario is also changing rapidly outside as we speak, even in India as well as outside. And there are many countries, they look at other countries' prices, and they call it international reference pricing. So, and mostly, like, for example, Germany is being referenced by multiple countries. So the price in Germany impacts multiple countries in Europe, even outside Europe. So any price going down in Germany impacts the other country's price. And this is another mechanism in the world they use to keep the pricing at a level. And if you recall now, another very relevant discussion which you are having all the time, and we are still not very clear. You know, the price in US and the price in Europe, there is a big difference. Okay. And Europe is far more stringent, far more regulated, whereas US, you get a higher price. Now, Trump is saying the most favored nation. So he's saying, and it is very disruptive, he's saying, okay, let's look at Europe, where your price, imagine it's a US company. They market the product in US. They also market the product in Europe. And he says, okay, let's look at Europe. Which European country you have the least price? Give me that price. Now, it is like, you can imagine what will happen. And the price drop, it is not a small drop. It's almost like maybe sometimes it's a quite significant drop. I don't want to say what kind of drop for each product is very different. But there is a big difference between the US price and the European price. And even in Europe, every single country is not the same. Maybe Germany, you get a one price, you get a slightly different price in UK. And then countries like particularly Greece, Portugal, you get another different price. I'm just giving an example. This may be true even tomorrow. Imagine in our countries, if you imagine each state could be like one euro perhaps country. So, and there, imagine all of them, health is a state subject, right? Correct me, Prashant, in India. So they have their allocation of the budget and they decide, there's okay, fine, national level we do, but the state level we also will negotiate. But I need to have the infrastructure. Similar situation here. So imagine that each state will look at each other state's pricing, or we have a central, right now it is national level, but in Europe, the international reference price plays a big role when you decide your pricing strategy. So not only the pricing strategy, your launch strategy. So where will you launch first? Where will you go second? Like first wave launch countries, second wave launch countries. So this is extremely important as a part of the pricing strategy.
Thank you, Ashis, for adding valuable insights to this. And thank you, everyone. I know we're a little tight on time, so I will request everyone to keep response as brief as head into the final segment. So for the next question, I would like to ask Minal ma'am. Ma'am, we often hear that real-world evidence is underused in India. What's your take on that? And how can a program like market access and pricing policy help professionals go from just collecting data to actually influencing decisions with it?
So I think this topic we have already covered, through the last 1 hour discussion we had. But again, retouching on, the very,
Just brief.
very briefly. So again, why is it being underused is one, because there's no standardization. The quality of the data is not at par. Again, because the way the data is being collected from a hospital or the physicians or even independent clinicians, offices. So I think the whole system is still so fragmented that the quality and the type of data that is being collected is not good enough so that you can use it and say that I'm going to do the analysis and predict some outcomes based on that. I think that is one. Again, how the program can help. I think first thing is the skill building. So I think this provides a very good platform for upscaling people, making them understand the importance of RWE, right? And I think for me, I think this platform, as I said earlier, is a very good place where you can bring all the major policy decision makers, right, from the government perspective, the pharmaceutical companies, even the clinical KOLs, because in India, a lot of it is also driven by, the KOLs, or, how can you change the treatment patterns, or how can you change the guidelines? Everything has to get impacted. It's not just one. You cannot work in different silos. So you have to bring all of these people together on one common platform, have a very engaging discussion, so that that okay, these are the outcomes. So I think from my perspective, this is a very good place to start off to create that kind of the platform and kickstart this process.
Thank you, ma'am. And ma'am, we know that every course or program fits not everyone. So who do you think this learning journey is not for, and who must explore it to stay relevant?
So according to me, anybody who's in the healthcare sector or anybody who's in the pharmaceutical sector, it's very relevant because as Dr. Manish also said, and for me, that was a very engaging discussion when you're talking about supply chain, right? And when you talk about the health economics, I can see the pull factor, how can that correlate with it? If I am going to go out and say, I'm going to change the prescribing patterns, if I can engage with the physicians and I can say, go ahead and prescribe this because this has a better efficacy or better value. So you can imagine then that pull factor can occur. And this is something that I was just listening to him and I realized, yes, it's not just HEOR, it's not about post, once the drug has been approved, right? Or it's not just about post-marketing surveillance or only the post reimbursement or driving the reimbursement. It can also affect your supply chain management. So anybody who is interested in this domain or who is interested or linked to the healthcare sector, I think this is very important because you never know, it can fit into so many other domains as we speak, right? So for graduates, for people who are already in the industry, for people who are, let's say, in the business analytics or competitive intelligence, for them also, this is a very important course or to understand, what health economics or market access or pricing is.
Thank you, ma'am. Thank you so much. I hope that our audience will be happy to know that and will participate for this program. And as we begin to wrap up this session, I would love to get a final thought from each of you. Why do you believe a focused program on the market access, pricing, and policy is important for pharma professionals today? I would like to hear from other panelists also for this question.
I would say that perspective shift, we are missing the bigger picture. So access and policy are not just back-to-back office compliance. Generally, we consider that. And as rightly said by Minal, is that access define the market, not just entry. So knowing the entire process of access is very important, critical for each and every person who is involved in the pharmaceutical industry. I would say that each and every person who is connecting in a continuum of the drug discovery to the final point when the patient is getting the medicine, this program is for all of them. So, and from my policy perspective, I would say that just 2 to 3 points. That's the policy shapes pricing and profitability from price caps under DPCO we are facing in India currently. But as rightly said by Ashish and other panelists, how to make a value-based pricing debates, how to talk about the real-world evidence, how to talk about the, I would say that the margins, the regulations which are impacting the entry of the drugs in India or in the procurement system, that we will learn during this course, how to mitigate those risks where we have the pricing for most of the time or the entry point, at which point and what price we are entering. To understand all those things, this course is going to be beneficial for each and everyone.
Thank you, sir. And any other speakers would like to add anything?
So actually a lot of insightful discussion, particularly the pricing, which I'm interested in. And Ashis probably has given a lot of thoughts to really, I mean, I'm currently teaching these executives the pricing strategy. So this Netflix model, which he said could be one of these models for pricing, or it's actually going to give me some thought to really, whether how come it is going to be a part of the pricing strategy in the context of the pharma. Of course, the course, is going to be very, very useful with respect to different aspect of, this pricing strategy. Particularly, I would say the market access is one. Here, probably people have to know like what is health economics and outcome research. In fact, I just want to tell you that when I was doing this particular course in Harvard University, so that was actually health economics outcome research. I think it was 5 years ago, 6 years ago. So that was a 7 days program, and exactly what we discussed, like in different facets of this program going to be, and it's really going to be very useful for the students, for the doctors, and of course to the pharmaceutical companies as well. So I think it's starting with the pricing, starting with the access, and also the policy perspective, which is very important actually, play a very important role for pricing. It's going to be very insightful, and people, those who are going to be part of this program are going to be immensely benefited for this from this program, NDP program. Thank you so much, and I'm looking forward to this as well.
Yeah, thank you. Thank you so much to all our incredible speakers for sharing such powerful insights today. From decoding global pricing trends to understanding how HEOR policy and access frameworks are reshaping pharma. This conversation truly spotlighted what the future demands from industry leaders. This is more than just a podcast, it's a preview of the transformational learning experience designed through the collaboration of Pharma State Academy and IIM Sirmaur. If you are a pharma professionals looking to move from tactical roles to strategic leadership, mastering market access, pricing policy, and HEOR, then this program is for you. Thank you for tuning into Humans of Pharma, and until next time, keep learning, keep leading, and keep building the future of healthcare. If anyone has any suggestions for our episode of Humans of Pharma, please feel free to reach out us on LinkedIn or our Instagram page, our YouTube, or you can just email us on our Pharma State Academy email ID. Thank you everyone for joining today. It was a great session.
Thank you. Thank you so much.
Thank you. Thank you very much.
Thank
Thank you,
you.
sir. Thank you,
Thank
ma'am.
you
Thank
all.
you.
Thank you,
Have
Ashish
a
sir.
good
Thank
day,
you.
everyone.
Yeah, yeah.
Okay, thank you.
Thank
you.
you. Thank you.